Now up next, a new book out on medical marijuana. Here's the discussion.
Welcome again. I'm George Woolreich, and welcome to the College of Physicians of Philadelphia. We are delighted tonight to bring one of the hand grenades of current thought and issues, medical marijuana. Not recreational use of marijuana, but should marijuana and its derivatives, the cannabinoids, be used for health purposes? A very controversial issue, and one in which frequently there's far more heat than light, and where we frequently see people who seem to be immune to data. But we have experts tonight to talk about this, and it will be moderated by Dr. David Casarett, who is Chief of Palliative Care at the University of Pennsylvania. I'm a psychiatrist, and I often think that most people, including many physicians, don't really understand what psychiatry is. Nobody understands what palliative care is, and it's a wonderful branch of medicine and needs to be better understood. Dr. Casarett launched a book here a year ago that was wonderful. This is his second book he's launching here. No, we do not have royalties on it, but I own 2 copies of it. So Dr. David Casarett will come up in a minute. We believe all of you are literate. We print biographies in the program. This is not grand rounds. I'm not going to sit up here for 10 minutes and read every paper that everybody wrote. But Dr. Casarett will come up, talk for a while, and then he will introduce our 3 panelists, and then he will moderate a discussion amongst them. If you have questions during the evening, there are note cards, I believe, that you can write on and pass them, and they will be collected. We'll also put a microphone up later for questions. Please don't interrupt the speakers, though, in the middle of the thing. Dr. David Casarett, please.
Thanks, everyone. It's delightful to be here again, a year later. Different topic, as divisive, as problematic, I think. I'm rearranging the script a little bit. I was supposed to ask this question in another half an hour, but I'd like to ask it now. I'd like to know what people in the audience think about legalizing medical marijuana in Pennsylvania. And I'll give you 3 options. You can either be for or against, or you can be undecided. And we'll ask that question later. So all of those of you who are for, okay. All of those of you who are against, some. Those of you who are undecided, which often means you have an opinion, you just don't want to state it for the record. It's okay, I've been there. So my goal in the next half an hour or so is not to change your minds. I'm not going to try to take all of those of you, or even one of those of you who are pro-legalization, and shift you. I'm certainly not going to take those of you who are negative and shift you the other direction, and I'm certainly not going to take anybody in the middle and try to nudge you one way or the other. And honestly, I shouldn't be able to do that. I mean, if you can be nudged that easily in the space of a half an hour for an issue that's this important, you probably haven't thought through it carefully enough. So that's not my goal, and that shouldn't be your goal here either. What I'd like to do in the next half an hour, and what I've asked our panelists to work on in the sessions that they have following this, is not to try to change your minds, but to try to give you enough data, enough evidence so you can have a thoughtful discussion to support whatever your opinion is, and to do that knowing what the other person on the other side of the debate thinks too. So what we're after here is not a consensus that medical marijuana either should or shouldn't be legal, but a thoughtful discussion, wherever that discussion ends up for any of you. Okay, fair enough? So, sponsors, thank you to all of these folks, and a special round of applause, if you could, for Jill Stahl, who's standing in the back there in the bright dress, who was responsible for doing all of the last-minute things, including getting me a glass of wine for free about 15 minutes ago, which really, really helped. So thanks for that. These are my conflicts of interest. I've asked the panelists also to describe their conflicts of interest. Is she for or against? I'll take that as an undecided. We'll work on that. I don't have any conflicts of interest. The views I'm about to describe are those of myself, not those of the University of Pennsylvania. I couldn't resist putting this picture. This appeared with a book review for Stoned. I showed this to some of our social workers on the palliative care service at the hospital of the University of Pennsylvania, asked them if this guy looked like me, and they said no, which was good, until they said, no, that guy is much more cute than you are. So thanks to all of you. This ultimately is the question I think we need to wrestle with, whether you're thinking about whether medical marijuana could help you or a loved one, or on a policy level, whether medical marijuana should be legal. Is it a medication? Is it a weed? Is it something that could be helpful? Is it an illegal drug that should be banned? Or maybe is there some middle ground that we could find a consensus about? I wrote the book Stoned for a patient I took care of about 1.5 years ago. This is a hospice patient who came to us. I had a conversation with her about some of her symptoms. She had advanced pancreatic cancer. She described to me symptoms of weight loss, nausea, pain that sounded like it had a neuropathic component, meaning pain due to nerve damage. And in the course of that conversation, she asked me whether I thought medical marijuana might be helpful for her. And I told her what I had learned in medical school, which is that medical marijuana doesn't exist. Marijuana is an illegal drug. There's no randomized controlled trial data to support its use. But what I didn't tell you about Judith is that she is a retired English professor, and she spent the last 50 years of her life giving students a tough time and cross-examining them. So when I said, no, there's no randomized controlled trial data to support medical marijuana use, she said, really? Because I went on the internet and I found a couple of studies, and here they are. And she pulled them out of her bag. And it was at that moment I had to admit to her that maybe this retired English professor knew a little bit more about medical marijuana and symptom management than I, as a palliative care physician, did. So I promised her that I would look at those papers. I'd look for other studies that had been published. And I would ask some of my colleagues, some experts in the field, and I would get back to her with an answer about whether, how medical marijuana might help her. And my advice to her was that, yeah, based on the evidence out there, it could certainly be helpful to her. But that realization that one of my patients with no medical training, a retired English professor, actually knew more about the evidence for medical marijuana than I did, made me realize that there are probably other people out there, policymakers in our legislature, patients, families, other physicians, who had the same perception that I did, that there's no evidence to support its use. So that's really what led me not just to research medical marijuana for Judith, but to also embark on this process of writing a book. And as I did, I came up with 3 big surprises, probably more than this, but in the next half hour or so, I'd like to walk you through these 3 big surprises. And just parenthetically, a couple people in the press interviews I've been doing for Stoned have asked me which science writers I find most influential for me, who I've looked to be role models in how to be a medical science writer. And there's certainly some, people like Jonah Lehrer and Mary Roach, I'm compared with a lot, sometimes favorably, sometimes not so, Oliver Sacks. But honestly, I think the most influential writing examples for me have been travel writing, travel narratives. The really, really good travel narratives by people like Paul Theroux and Jonathan Rabin, Pico Iyer, Jan Morris. These are people who write travel narratives really, really well. And what makes a really good travel narrative is mistakes and surprises and misconceptions that get rearranged along the way. Good travel narratives aren't really about getting from point A to point B. It's about trying to get from point A to point B and winding up somewhere else entirely. Or maybe getting to point B in the end and realizing it's not at all what you thought it was going to be. And so when I think of what a good science nonfiction in the medical vein looks like, it's kind of like travel writing in a way. And so that's what I'll try to share with you. It's the ways that researching this book, talking to a lot of patients, researchers, reviewing a lot of studies, talking to a lot of physicians, visiting clinics, trying medical marijuana for myself, what that's taught me, not only in terms of the science, but really in terms of surprises and ways in which I've been surprised, and frankly, the ways in which I've been wrong. So the first that I'll tell you about is that there seems to be a science of the way that medical marijuana works. The second is that, as my English professor told me, medical marijuana does have benefits. And third, that it has risks, although not necessarily the risks that I expected. And I'll walk you through each of these. So there's a science of medical marijuana. I really thought that medical marijuana, or the appeal of it, was just about getting stoned. It was the feeling of being high. It was the chance to forget whatever else was going on with you, whether that was a terminal diagnosis or pain or nausea. It was something that was dissociative. I mean, it kept us from focusing on whatever else was going on, but it wasn't really therapeutically valuable. That's what I thought. A little bit of background is useful. Two main species of marijuana. Some people argue that a third species, ruderalis, is a true species. Some people would mix it in with these two. But generally, when we're talking about medical marijuana or recreational marijuana, we're talking about two species. When we're talking about the active ingredients of marijuana, which I'll show you in a second, the big ones, the main ones that we know the most about are THC, or tetrahydrocannabinol, CBD, cannabidiol. Those are present in these little trichome that look sort of like nail heads that appear in the buds and to a lesser degree on the leaves and stems. So when you're talking about the cannabinoids in medical marijuana, you're really not talking about the entire plant. You're talking about what's highly concentrated in those little nail head things. You're really talking about these two molecules. There are a bunch more. There are dozens of cannabinoids out there. It's really THC and CBD that we know the most about. They're present in the largest amounts. They've gotten the most attention in terms of what's been studied. But keep in mind, although what I'll talk about in terms of benefits, and a lot of what you'll hear from the panelists will be benefits for THC and CBD, keep in mind there are a lot of other cannabinoids in marijuana, many of which we have no idea what they do. But there's certainly reason to believe they could be therapeutic as well, or they could pose risk that we don't yet understand. Another surprise for me in this overarching category was that marijuana, THC, CBD, other cannabinoids act through receptors. It's not just a global feeling of being high, but there are very, very specific effects. CB1 and CB2 receptors, so-called, in the brain, also in the reproductive system. CBD seems to bind to other receptors, mostly in the immune system, potentially elsewhere in the body as well. And also, interestingly, in microglial cells in the brain, which have led several scientists I talked to, including Donald Abrams at UCSF and Barth Wilsey at UC Davis, to begin to think that CBD may be very, very useful in treating pain, particularly neuropathic pain, pain due to nerve damage, and pain due to muscle spasm and multiple sclerosis. Other cannabinoids, as I told you before, other receptors as well. This is just one angle of one snapshot of what we know. What really convinced me, though, that there was a science to medical marijuana that I really hadn't appreciated is that Raphael Mechoulam, who's pictured here, is arguably the grandfather of medical marijuana. I made a trip, a pilgrimage would probably be a better term, to meet Dr. Mechoulam in his laboratory at Hebrew University in Jerusalem to hear about, some of his work. And he was, in addition to other things that he's done, he was the one who discovered with Bill Devane anandamide, so-called as the bliss molecule, from the Sanskrit. And anandamide is interesting for us because it gives us a sense of how marijuana, THC and CBD in particular, do what they do. We don't have, and this was a surprise to me, we don't have, or we're not born with, receptors that are designed to bind to THC. We're not born with THC receptors. We are, however, born with anandamide receptors. And so when you take THC into your body in the form of marijuana that's inhaled or vaporized or eaten in the form of an edible, what you're doing really is tricking the body into thinking that it's suddenly experiencing an inrush of anandamide. I'm oversimplifying a little bit, but just a little bit. So you're basically hacking into the natural endocannabinoid system, and you're convincing the body that it's suddenly seeing a lot of anandamide. And the reason that's important, it's kind of neat, it's kind of interesting, but the reason it's important is the endocannabinoid system is really very complicated. It's present in the immune system, in the brain certainly, in most organs, at least to some degree. It's also, by the way, present in pretty much every species out there except for insects for reasons which I don't really understand. So when you're using medical marijuana or recreational marijuana, when you're taking THC, for instance, into your system, you're really hacking into a very complicated system that we don't quite understand. So not only is the science of medical marijuana much more complicated than just getting stoned, it's even more complicated than just one molecule binding to one or two receptors in the brain. You're really tapping into a really complex, in ways that are kind of hard to understand right now, and I don't think we have a full idea of, but you're tapping into a very complicated system in the body. So that was one surprise, that there was really some science, there's microbiology, there are receptors, there are also natural variations in receptors. Your cannabinoid receptors are not the same as mine, and so how you respond is different potentially than the way I would respond to a joint or a gummy bear or a brownie. So that was one surprise. The other surprise is that medical marijuana really does have benefits. I really, as I said before, thought medical marijuana was a joke starting out, but I had to admit, based on some of the studies that Judith showed me and some of the studies and researchers that I saw and talked with, there really is some good data out there. Increasingly, there's a picture of a vaporizer here, because increasingly some of the best data on marijuana for a variety of indications, including pain, come from these vaporizers. So the science behind vaporizers is that you heat a marijuana bud, usually, to a temperature that's hot enough to make the cannabinoids, THC and CBD for the most part, evaporate, turn into vapor, but not hot enough to get the stuff in marijuana to burn. So you're inhaling pure THC and CBD, but you're not inhaling all of the gross burning particulates that you would get when you inhale, say, a joint or a cigarette, for the most part. So there's some really interesting studies that are coming through now. Donald Abram at UCSF was one of the ones who pioneered that in research, but other people are starting to use it too, which seems to be a cleaner, potentially even easier to titrate way to figure out whether people are getting the doses of cannabinoids that you think they are, which is useful for research purposes. This is what one dispensary owner told me. I said that there are benefits to medical marijuana. I wouldn't go this far. But one thing I've discovered in looking through the world of medical marijuana, particularly dispensary owners, particularly those people who have a vested interest in pushing medical marijuana, is that there are a lot of overstated claims. So I would say that there are medical benefits to marijuana. I would not say that it's the new best thing. I'd not say it's a wonder drug. It doesn't cure all ills. It doesn't cure cancer. We'll just say that for the record. If you look at state laws, including some of the indications that are included in some of the legislation that's moving through Pennsylvania, you see very long lists of things that are listed as qualifying conditions. That's one interesting fact. The other interesting fact is there isn't a huge amount of agreement from state to state. So what's a qualifying condition in one state may not be a qualifying condition in another state, which is fascinating when you think about it, because either there's enough evidence to support the use of medical marijuana for PTSD or chemotherapy-induced nausea, or there isn't. But it's not like that evidence would be greater in California than it would be in Colorado. And yet there doesn't seem to be a huge amount of agreement from state to state. But there are lots of ideas out there about how medical marijuana can help. So how much is there, really, of medical benefit from medical marijuana? I could spend probably a couple of hours walking you through the evidence. It would be a very, very efficient way of putting you all to sleep, which I will not do. There's an article, though, that was published in JAMA, the Journal of the American Medical Association, just about a month ago now, that was a very carefully done, if somewhat stringent, review of the evidence of both smoked marijuana and cannabinoids, both natural and synthetic. And they summarized the evidence more thoroughly than I could reasonably do in a short period of time. So I'll just tell you what they found. And this, more or less, is what they found. That there is some evidence, but probably not as much evidence as a lot of people would like, and certainly not as much evidence as many patients who are looking to medical marijuana for relief would hope would be available. These are their designations, not mine, but moderate evidence for neuropathic pain, spasticity, particularly in multiple sclerosis, weak evidence for some of these other indications that I've listed. And I remember looking at that list thinking, that's a little bit odd, because that's not entirely diametrically opposed to what I said in Stoned or the impression that I got, but it seemed like it was a little bit tougher, a little bit more harsh than what I thought. And so I decided to unpack this a little bit. So remember that they said there was only moderate evidence for the benefits of medical marijuana for neuropathic pain. And so I just picked one study, more or less at random. This was done by Barth Wilsey at UC Davis, who I mentioned earlier. A reasonably well done study published in a decent journal. And it was a study that I cite as evidence that there does seem to be at least a reasonable amount of fairly impressive evidence that medical marijuana is useful in the treatment of neuropathic pain. If you unpack that a little bit based on that journal article's criteria, there are some notable strengths, right? Randomized controlled trial, there was placebo control. And by the way, you can actually get placebo marijuana. That's another surprise to me in writing this book. You can actually remove the THC and CBD from marijuana in pretty much the same way you remove caffeine from coffee beans. It's chemically the same process. Both processes seem really kind of a stupid waste of time to me. I'm not really sure why you'd want to do either one of those, unless, of course, you're a researcher. So many of these studies use placebo marijuana. Wilsey's study also used low and high dose groups to detect dose effects. But in that JAMA article, they also pointed out two weaknesses: only 39 subjects and imperfect blinding, meaning some of the people in the placebo group, some of the people in the active group knew how they were assigned, knew what they were getting, which makes sense if you think about it, right? I mean, if you can't tell whether you're getting real, honest-to-God marijuana or the pharmacologic equivalent of oregano, you're probably not paying attention. So yeah, some people managed to figure out that they were in the placebo group or the active group. But those two weaknesses, in quotes, were enough to downgrade that study that I just showed you, despite the fact that it was a placebo-controlled, randomized controlled trial, to a poor quality study. And I don't mean to argue with those criteria. They could use whatever criteria they feel are important. But keep in mind that those criteria really are pretty tough. Those criteria are also tough because right now there's no federal funding for medical marijuana research, right? So those of you who are researchers know it's really hard to do large randomized controlled trials. This grading criteria that the JAMA article I mentioned used called it a small study if there were fewer than 200 people. And that's pretty much every single study of medical marijuana that's out there. So it's really hard to do studies that would hold up to that level of evidence that JAMA article would call strong. Again, I'm not saying that's the wrong criterion, but when we hear discussions of evidence as being weak or moderate or strong, it's important to know, as educated consumers, policymakers, physicians, patients, it's important to know what that means. And again, rather than summarizing the evidence and talking about nuances here, what I thought would be most useful is to pose this question for you, because I think this really gets to the heart of a lot of the debate about medical marijuana and how we should think about it, and that's how much evidence do we really need? And I think the answer to that question depends on who you are. If you're a policymaker, if you're a hardcore researcher, the amount of evidence you'd want to make sure that a new treatment, whether it's a new implantable cardiac device or a form of medical marijuana, to be sure that it actually works, you'd want multiple large, meaning several hundred people, randomized controlled trials, right? But here's the thing. If you're a patient, as were many of the patients I spoke with, one young guy in his 20s had a bad but treatable form of lymphoma, was having just awful, horrendous nausea after every round of chemotherapy, so bad he couldn't even leave the house for a period of about a week. Nausea that was so bad that he was actually thinking, this is a 24-year-old who's thinking about stopping his chemotherapy for lymphoma and enrolling in hospice just because he couldn't stand the nausea. Had been through 4 or 5 different types of anti-nausea medication. When his doctor finally recommended he lived in California, when his doctor finally recommended that he try medical marijuana, he said sure, he'd give it a try. And I tell you that story because his threshold for evidence is probably going to be a little bit different and probably a little bit lower than that of an administrator at the Food and Drug Administration or a hardcore researcher. I'm not saying that one of those two is right. The administrator at the FDA, his or her job is to protect the public. So their job is going to be to ask for the highest possible level of evidence. But if you're that kid trying to struggle through chemotherapy, or if you're a parent who's trying to get CBD oil for your kid with intractable seizures, or a guy who's suffering through PTSD, like somebody I met when I was researching Stoned, had been through a dozen different medications, a couple of suicide attempts, really needed some form of relief, your level of evidence, your threshold for what constitutes enough evidence is going to be different. And again, I'm not trying to privilege one of those positions, but I think when I hear people arguing about whether there's enough evidence, I think often what's going on is that people know exactly how much evidence there is, but they just have a different cut point for what constitutes enough evidence. So maybe think about that going forward as we enter the debate phase of this evening, and use that to parse out some of your thoughts and some of the discussion. The other thing that I've learned, just thinking about the potential benefits of medical marijuana, this is an op-ed that I wrote for the New York Times, which for a brief period of time was trending as one of the most emailed articles in the New York Times, ahead of Paul Krugman, which I thought was pretty cool. Behind, though, unfortunately, an article about sending puppies to prison to be therapy dogs. So I beat Paul Krugman, but I lost to puppies. But the point of the article, though, which has gotten a lot of traction, has made me think a lot about what medical marijuana means, especially in light of the discussion we just had about levels of evidence. I think if it seems, and this is probably fair, if it seems like the utilization of medical marijuana is getting ahead of the evidence, meaning more people are using it for more indications than are really supported by randomized controlled trials, and I think that's fair. I think part of the reason for that is that the health system, for the most part, doesn't do a great job of taking care of patients who need extra attention, extra support, extra education, certainly good symptom management. And I feel comfortable saying that. There are many people from the palliative care team who I work with and from Penn's hospice program. I think we're able to do a pretty good job. But I think in general, because that's our job, but I think in general the health system doesn't. And I've begun to see a lot of the interest in medical marijuana, not so much based on a belief in the evidence, partly that, but also based on dissatisfaction with having to go to a physician, not having time to address concerns, being in and out in 10 minutes without really having the support and advice that you need. And people are getting it, as I discovered, from medical marijuana clinics and really from dispensaries. It's a chance for many patients, including some I spoke with when I was researching Stone, to begin to take control over their illness. I promised you 3 surprises. The third one, briefly. Medical marijuana does have risks. A few of them we're pretty sure about, a whole bunch are speculative, and then others are things that I didn't expect, and I'll walk you through those quickly. This is something else that I heard from dispensary owners, something else that is just, frankly, not true. Those of you with medical training will notice that there's a logical flaw in this argument. Marijuana doesn't have any risks. The flower, not like morphine. Morphine is an opioid. Opioids are derived from poppies. Poppies, last time I checked, are flowers, right? But this is a dispensary owner who is very convinced that because marijuana is natural, because it's a flower, it has to be safe, which is obviously not true. A few known risks: driving impairment, addiction. Believe it or not, I honestly did not think addiction was a significant risk of marijuana. It's probably not as significant as addiction to cocaine or heroin, to be fair, but it's probably on par with something like alcohol, for instance, both in terms of risks of addiction, risk of dependence, maybe not in terms of health consequences. There's certainly lots of downstream health consequences, including liver damage, to alcohol addiction that don't occur with marijuana. Hyperemesis syndrome, an odd syndrome we don't really understand, that involves, as it sounds, of intractable nausea and vomiting, which is odd because marijuana is often used to treat nausea and vomiting. Stops with cessation of medical marijuana, also can be treated with a hot shower for reasons that I at least don't understand. Known risks, a lot of unknown risks. And these are listed in no particular order, and honestly, if we had more time, I would walk you through, as I do in Stoned, where I think the evidence lies for each of these. I think some of these are probably more likely than others. Psychotic episodes, yeah, maybe. Myocardial infarction, stroke, I think probably not. Long-term cognitive dysfunction, I don't think we really know yet, but we probably will find out in the next few years. Not cancer, not lung disease, and I just wanted to call those out quickly, because those are the areas in which there have been a lot of very large, very, very well done studies. I spent some time talking with Donald Tashkin, who's a pulmonary function test physician, a pulmonologist at UCLA. in Los Angeles, and he's done some of the biggest, best studies of lung function over time, and he's found that there really isn't any decrease in lung function, no increased risk of emphysema from chronic marijuana smoking, which makes no sense, right? Like the stuff that you inhale when you smoke a joint is exactly, more or less, the stuff that you inhale when you smoke cigarettes. So why doesn't that cause emphysema? There are a couple of explanations, some theoretical. Probably the simplest one is the most obvious and the most logical to me, and that's a matter of dose. I used to work in the VA. Many of the veterans I took care of would smoke 2 or 3 packs of cigarettes a day for 30 or 40 years. So that's often, for many people, what it takes, the dose, if you will, what it takes to cause lung damage. Imagine, just for a moment, what you'd be like if you smoked 40 or 60 joints a day for 30 or 40 years. Your pulmonary function test results would be the least of your problems, right? So it may be that if you really managed to smoke that much, which would take real guts, real determination, if anybody wants to try it, go for it. If you were able to really smoke that much, yeah, you might wind up with emphysema. But in the way that most people smoke, it's really not a concern. And obviously edibles, vaporizing, it's not a concern at all. Another surprise for me. It's worth pointing out that there's some flaws in the existing data we've got. Lots and lots and lots of case reports. So somebody used marijuana recreationally often and then had something bad happen to them. And then that results in a case report in the literature. That doesn't necessarily mean that marijuana use caused that, whatever it is. It's possible to find case reports, if you really wanted to, of somebody eating strawberry ice cream and then having a migraine. Is that cause and effect, or is that coincidence? So it really takes a lot to try to sort through that. The second point is probably one of the most important, and that is we really don't have any good safety studies of medical marijuana. Lots and lots and lots of studies of recreational marijuana use, but there's some important differences. And it's also really hard and also probably kind of risky to generalize from studies of recreational marijuana use to medical use. So it may be, just hypothetically, that a 24-year-old who uses marijuana recreationally 4 or 5 times a week, along with other drugs like meth, mollies, other things, it is at increased risk of a psychotic episode in the next 2 or 3 years, maybe. But does that mean that an administrative assistant in the oncology division at the University of Pennsylvania who uses marijuana once a week to get to sleep, is she also at risk in the same way? I don't think so, but we don't know. I think that's the bottom line, because all the studies that have been done really have been done on recreational marijuana use with often a whole lot of other drugs in a very, very different setting. And many of those studies can't control for all the other things that go on. So here's a challenge for you, and this is something that we need to think about as we begin to wrap up. As I've tried to describe to you, medical marijuana use is common. There are probably, rough guess, about at least 1 million people who are registered medical marijuana users around the country. And for every person who is a registered user in a state program, there are probably several, maybe a dozen more, who are not registered or who are using illegally. So that million figure is probably a vast underestimate. It would be nice if we had randomized controlled trial data to support every single use, that guy using it for PTSD, the woman using it for chemotherapy-induced nausea, the guy who's using it for spasticity related to multiple sclerosis. It would be great if we had all those clinical trials, but we don't. And honestly, we're probably not going to have an adequate bank of clinical trials really in the next 5 or 10 years, probably more. Again, no federal funding for research. It's really going to be hard to build that bank of clinical evidence up. So what I've started to think about, and what I'd ask you to think about too, is how we can get better at crowdsourcing research, how we can get better at learning from the experiences that people have. I mean, think about that for a moment. 1 million registered users around the country. There's really no organized way to collect data about their experiences. There's no organized way to collect data about their long-term effects, side effects, and risks. So there's a lot of experience out there that's going to waste. I don't really know what to do about that. Some students that I at Penn created marijuanaresults.org, which is currently just in beta testing. You could probably use it if you wanted to. It probably wouldn't take much to crash the server though, so I wouldn't recommend that many people do it. But we did this as a thought experiment to see whether it would be possible to get patients to collect and report data both so we could learn from each other and also so researchers could learn from patients. If you see 5 reports of somebody using marijuana for a benign tremor, that's interesting. But if you see 50 or 100 or 200 or 500, then some researchers probably going to start paying attention and thinking, well, we should really do a randomized controlled trial. But the advantage, though, is that we'd be using crowdsourcing results to begin to point research randomized controlled trials in the right direction based on what reports are. So I took you through 3 surprises. Briefly, there really is a science out there, which was a surprise to me. There are medical benefits, probably not as many as some dispensary owners claim, but probably more than some of the people who oppose medical marijuana would admit. It also has risks, which I think everybody needs to admit, although, as I told you with the smoking example, not necessarily the risks that you think about. So, medication, weed, I'll leave that to you to think about, and the panelists to help you think through significant benefits, real risks. Hard to say it's a medication because one plant is one plant. It's not a medication necessarily in the same way that an amoxicillin pill is a medication. But there certainly are molecules in marijuana, in the cannabis plant, that do have real physiologic effects, and some of those effects are beneficial. So think about what terminology you want to use, but hopefully I've given you at least enough facts related to science, related to benefits and risks to think, as Ralph Waldo Emerson did, although I don't think he was thinking about medical marijuana, did as he thought through that as well. So I have a couple of thank yous to many people who I interviewed along the way, including Sasha the Wonder Dog, who is this wonderful German Shepherd who stands guard over this wonderful dispensary in California outside of San Diego. It's like the perfect clinical environment. I think if all of the Penn outpatient clinics had a German Shepherd like Sasha, our patient satisfaction scores would be through the roof. All of our patients would be happy. And I think, honestly, our physicians and nurses would be a whole lot happier, too. So let me stop there. Let me thank you for being very attentive as I walked through probably more science than you really wanted to hear, especially in this time of the evening, but you've been very patient, so thanks for that. Next, I am going to introduce our panel briefly, although I'm looking to Jill for advice. Jill, am I going to introduce our panel briefly? Jill is nodding. I'm going to introduce our panel briefly, and I'll ask them all to come up. You have in your handouts their bios, please. Just a wave. Come up. You have their bios. I will not walk through their bios. I'll also invite them to say a few words about themselves if there are elements of their bios that underrepresent them. To my far right, and we have decided, we've made an executive decision amongst us, we'll use first names. So in the question and answer session, as you begin to pass questions forward, please refer to me as Dave. To my far right, Will Jones, who joins us from Washington, D.C., Steve Auerbach, who joins us from here, and Joseph, who joins us also from Philadelphia. We will ask them to do 10-minute presentations. As they do, if people have questions, I would ask them to be passed forward to me. I'll probably, if it's okay, save those questions until we actually get through their presentations, because I really want them to have a chance to give you a sense of their perspective, especially since, although I've tried to give you an unbiased view, I'm also aware that what I told you could certainly be perceived as having one directionality or another. So I want to give them a chance to set the stage a different way if they feel that's appropriate. A couple of requests to everybody along the way. This goes for the panel, all of us, also a reminder to me. This is a topic that lots of people feel very strongly about, either because you have political or intellectual leanings in a particular direction. Some of you have your own personal health experiences or those of a family member. In short, it's something that a lot of people feel strongly about. So I would encourage you, because of that, to be extra careful, to be courteous in your comments and your questions. Last but not least, it's probably not going to surprise you to learn, after having looked at people's bios, that there is both a spectrum of views about medical marijuana represented before you among the panelists and myself, and that Will Jones is probably on the more conservative end. And given how many hands went up in favor of medical marijuana when I did that poll about 30 minutes ago, I would ask us all to be particularly respectful of Will Jones, reminding us all that he is a guest here in Philadelphia. I promised him that people in Philadelphia are much nicer and more polite than the politicians he's used to dealing with in Washington. I also promised him that we have much better restaurants than they do. I also promised him we had nicer weather, so 2 out of 3 isn't bad, but please don't make me a liar on that first one. I have no doubt that Mr. Jones can take care of himself, but he is a guest, and I would ask us all to be respectful. Gentlemen, do we have an order? I'm glad, because I don't have an order. Mr. Joseph, take it away.
Thank you very much.
Jill and I will be very, very tough timekeepers, so beware.
David is a hard act to follow, so I'm going to call for help from a past president of the College of Physicians, Dr. Hobart Amory Hare, who wrote in 1887 and published in the Therapeutic Gazette Clinical and Physiological Notes on the Action of Cannabis Indica. Quote, cannabis indica has been before the profession for many years as a remedy to be used in combating almost all forms of pain. Yet, owing to the variations found to exist as to its activity, it has not received the confidence which I think it now deserves. I agree, President Hare. He wrote these words in 1887. He was president of this college, 1925 to 1928. When he wrote this, he was a professor of materia medica, or medical materials, or pharmacology, or therapeutics, at Jefferson, a few blocks away. So let's fast forward a little bit to a more recent source of materia medica, this wonderful book called Cannabis Pharmacy. Published last year, it goes over many different medical conditions, far more than were on David's list, as well as a discussion of dosing, strains, and methods of administration. You see, back when cannabis was a medicine, it was generally only available as tinctures. This is an example of a photograph of cannabis indica, as it was called at that time, in a tincture form prior to its being banned for political and racial reasons in 1937. There were other forms. This comes from Australia, Canadana, a combination of cannabis and belladonna, which was used for excess mucus conditions and hay fever. The pharmacology is excellent to this very day, although we have drugs for these conditions with fewer side effects. Cannabis was part of American medicine even beyond the president's era, and the portrait of the president is in the middle upper row, who I began to talk with. The textbook I have is The Principles and Practices of Medicine by Sir William Osler, the 1914 edition. He was also a professor at the University of Pennsylvania. The co-author, Thomas McRae, was a professor at Jefferson Medical College a few blocks away. This college sits in between them. So I just want to quote one thing from this book, one of many things about cannabis, and this is under cannabis indica, under migraine, that cannabis indica is probably the best remedy, the most satisfactory remedy. Seguin recommends a prolonged course of the drug. Seguin was Edward Seguin, a professor, president of the New York Neurological Society, and a professor of Columbia. So cannabis was part of American history, and as nothing is new under the sun, it's being rediscovered. Now, there's more to cannabis the plant than CBD and THC. There are many other cannabinoids which are known, which are present in small quantity, and which influence the effect of the other cannabinoids. This is called the entourage effect, or the whole is greater than the individual parts. As an analogy, one could have a diet of totally processed foods and take vitamins and live. Or one could eat very healthy foods, fresh fruits and vegetables, nuts, oils, extra virgin olive oil, etc., and live and glow. The difference is the sum or the whole is greater than the individual parts. And that's the mystery of the cannabis plant. In addition to several cannabinoids besides CBD and THC, the plant also contains terpenes. Terpenes are found in many other plants. They're generally recognized as safe. They have activities that are impacted through smelling, and this is what gives different strains, different odors, different colors. Terpenes and cannabinoids together also have entourage effects, and this is the reason why one strain and another strain of the plant may have identical qualities or quantities of THC and CBD, but the other cannabinoids and the other terpenes are going to make the difference in the therapeutic effect. For example, classically, sativa strains are considered stimulating or activating. Indica strains are considered sedating. So for somebody with severe pain who can't get out of bed, what may be called a sativa strain may be more useful for them. For somebody with inflammation, arthritis, Crohn's disease, who wants to go to sleep, the indica strain may be a better choice for them. I want to talk about a little-known federal program that has been supplying medical cannabis for a very long time to a very small group of patients. This can represents 300 cannabis cigarettes, Schedule I, that the federal government has been giving to Irvin Roosevelt for about 33 years. Irvin wrote a book about it called My Medicine, How I Convinced the US Government to Provide Marijuana, and helped launch a national movement. Medical marijuana, in large part, is due to his efforts. See, Irvin has a very rare bone disease, and he discovered by serendipity that smoking cannabis worked, and he tested this on and off, and sure enough, it provided more relief for him than any other medication, including FDA-approved THC, which is also called dronabinol. So I want to basically stress that there is a lot of ingredients in cannabis. We don't know about all of them, but there are effects from the plant that are not present in the isolated ingredients. That each strain has slightly different qualities. In fact, they may even be referred to as a scientific treasure trove. Also, our body's endocannabinoid system is very important, from the implementation of a blastocyst, the earliest part of pregnancy, to what stimulates a newborn baby to drink. It's the presence of the endocannabinoid anandamide in the mother's breast milk that gives the little newborn baby, if you will, the munchies, that results in their getting nutrition. So the endocannabinoid system is a master physiological system that works through retrograde signaling. It helps restore and balance tone. It helps modulate some of the other neurotransmitters. In fact, people who use cannabis medically can reduce their opioid use by perhaps up to 50% because of the interactions. Also, opioid addicts who have access to medical cannabis are more successful in their recovery from opioids. I'm sure you're going to have a lot of questions. I've only begun to scratch the surface. Thank you very much.
Everyone, I'm Steve Auerbach. I would like to thank David, Joseph, and Will, my co-panelists here, and I'd also like to thank the college for both inviting us to speak and also, particularly on a personal note, in advertising of this event, not having my picture next to a big reefer leaf. That's all I need, you know, as a lawyer with a big pot leaf. I represent a couple business people who are interested in opening up dispensaries here in Pennsylvania. I represent some Amish who are interested in growing hemp. So it's an interesting dynamic. You know, do I want to be the pot lawyer, or do I want to be a business attorney who happens to represent cannabis interests? So it's an interesting place. So again, thank you to the college for not having my picture next to a big pot leaf. I was asked to give just a bit of a synopsis of where we are legislatively here in Pennsylvania. I'm going to talk about some of the political movements, what a medical marijuana infrastructure will look like here in the state, and as a transition to Will, some of my personal reservations here. So last year we had a bill, it was Senate Bill 1182, and it passed unanimously Senate subcommittee. It passed 43-7 in the Senate, but got stalled in the House. This was the then Medical Cannabis Act, and got renamed when it was reintroduced by Senators Falmer and Leach as Senate Bill 3. And this showed the legislative priority that we're taking it from 1182 to now 3, that we reserve the title, and this is something we're going to help our sick veterans, our sick kids, people suffering from ALS, multiple sclerosis, traumatic brain injuries, cancer, very serious debilitating medical conditions that we quite frankly can't wait for federal government to step up to the plate. The political climate has changed precipitously here in Pennsylvania, and that's attributable to many factors. When I first started talking about medical cannabis in Pennsylvania, there were a couple very significant polls of what people thought about medical cannabis in Pennsylvania. And then it was hovering at 84-85%. This is University of Quinnipiac and Franklin Marshall, very reputable polling agencies. Right now it's hovering at 88-89% of Pennsylvanians. That figure, people in Pennsylvania at least with cannabis, they don't just check a box, are you favor, are you against it, undecided. That figure actually translates to the ballot box. So 100% of the people politicians who put their name on the then Senate Bill 1182 won re-elections on their primaries by a landslide. So I'm talking Blake, Tartaglione, Williams, Wozniak, and Falmer. I mean, Falmer ran unopposed, but 100% of the people who put their name on this medical cannabis bill won re-election by a landslide. And that was not them just bowing and graciously to political pressure, to people in normal t-shirts. It's people that are taking a great interest into medical opinions. 20 minutes today I took and I just perused the internet of medical societies that were supportive of this bill and medical marijuana legalization, specifically for medical purposes. I'll just spend 20 seconds naming a couple. American Medical Association, American Nurses Association, American College of Physicians, American Public Health Association, Alaska Medical Association, Alaska Nurses Association, California Medical Association, California Nurses Association, California Pharmacists Association, California Society of Addiction Medicine, Colorado Nurses Association, Connecticut Nurses Association, Epilepsy Foundation, Federation of American Scientists, Florida Medical Association, Guam Medical Association, Hawaii Medical Association, Hawaii Nurses Association, Leukemia and Lymphoma Society, Medical Society of the State of New York, Mississippi Nurses Association, New Hampshire Medical Association, New Jersey Nurses Association, New Mexico Medical Association, New Mexico Nurses Association, New York Medical Society, New York AIDS Advisory Council, New York Nurses Association, New York Nurses Association, North Carolina Nurses Association, Rhode Island Medical Society, Rhode Island State Nurses Association, San Francisco Medical Society, Texas Nurses Association, Virginia Nurses Association, Virginia Nurses Society on Addictions, Washington Medical Association, Wisconsin Nurses Association, Wisconsin Public Health Association. Try to do it all in one breath, but couldn't do it. The then Senate Bill 1182 was then reintroduced by Senators Fulmer and Leach as Senate Bill 3. And this, again, unanimously passed the Senate subcommittee and passed 40-7 in the full Senate. And it used Senate Bill 1182 as a marker, but it added precipitously to help more and more Pennsylvanians. It had chronic pain to treat those suffering from severe neuropathic pain. It added other functions to help people with diabetes, and was brought over to the House, but unfortunately got stalled in the House. It's currently being redrafted and being fit into another bill, under House Bill 1432. We are hopeful that we'll be able to have this out of committee by early fall, still having our fingers crossed. Senate Bill 3, which this is going to be the framework, contemplated limited numbers of licenses of who can actually open up dispensaries. It had limited licenses for people who were going to open up a dispensary, people who were going to process the plant, and people who were going to then sell it. There were going to be 65 licenses for growers, 65 for processors, and 130 for dispensaries. We're expecting that this number is going to be cut down, which is unfortunate because there's over 12 million people in this Commonwealth. Compare 130 dispensaries to how many state liquor stores there are. There's 601 liquor stores. It's a very arbitrary and low number. One of my fears is that someone in Dewshore, Pennsylvania is going to be in an area where he can't get access to his medicine. Because someone who wants to open up a dispensary is not going to want to be in a low patient area, understandably. So if we're already limiting the number of dispensaries, I fear tremendously for our veterans who live out in the countryside. A couple benefits of what we're going to see in this House Bill 1432 is that it's not going to be a constitutional amendment. One of the things that we saw in Florida, and the reason that we don't have full medical cannabis in Florida, is because they tried to push it through as a constitutional amendment. And the reason for that is because we wanted to ensure patient protection, that we couldn't have another Tom Corbett come in and usurp our right to patient protection. So we're going straight through the legislative process here. The next is Senate Bill 3, or the HB 1432, is not going to turn Pennsylvania into California. My impression of California is that it's a de facto legalization. In Pennsylvania, a patient will need to have a pre-existing relationship with the doctor not predicated on the dispensation of cannabis. So in Pennsylvania, I've been told that if you have, in California, I've been told, and perhaps David could confirm this, that if you have $75, you can walk up to a doctor with a good story and you're getting a recommendation. That's not going to be the case in Pennsylvania. You're going to have a doctor with whom you have a pre-existing relationship. He's going to have to review your chart. You're going to have to go back for exams. This is a medicine quite similar to everything else we're going to see. The next is that this is not going to be CBD only. CBD has gotten a lot of attention recently. CBD is a as David has mentioned, is a non-psychotropic component of cannabis. There are hundreds of components in cannabis. CBD does not get you high. CBD has been shown to help tremendously with kids who suffer Dravet syndrome, people debilitating epilepsy. In Pennsylvania, children who suffer from epilepsy can have hundreds of epileptic episodes a day, some of them lasting 20 minutes in duration. We give these kids up to 7 narcotics, some of which are Xanax. I mean, can you imagine giving a 7-year-old Xanax? But in Colorado, states where we have legal access, safe access to cannabis, they're given CBD. You cannot get high from it. And there's 200, 300, 400, up to 700 epileptic episodes a week go down to 1 to 0. The problems we're now seeing in those states is these kids who are addicted to Xanax from birth because that's what we've been giving them. They're now 7, 8, 9 years old, and their parents are trying to get them in rehab to kick the Xanax. I mean, these are the problems we're now having. Unfortunately, Pennsylvania, it's not CBD only. We're going to be more inclusive. We're going to be having THC that's going to help our veterans, because THC actually activates some of the conditions. The next thing that we're going to see, well, I just got the 1 minute mark, so I'm going to give the transition to Will. One of my concerns, and when I started the Cannabis Growers Association in Pennsylvania and was asked to become the chapter president of the Pennsylvania Medical Cannabis Society, is edibles. I have friends who have dispensaries in Colorado, and when I visited them, quite candidly, and it's going to give a segue to Will, is one of my fears was seeing the gummy bears and the gummy worms and the cookies and things that are attractive to children. Quite candidly, I have a 3.5-year-old at home right now, hopefully sleeping. And I think it's frightening that we have medicine that could be attractive and attracting to children. So one of the things in Pennsylvania, we're going to make sure that our dispensaries do not have these things. I don't think medicine should be attractive to children. So that's all my time today.
Hello, everyone. And as I could see from the raise of hands, I'm definitely in the minority here, actually in more ways than one. But that's not a problem for me, and I appreciate the invitation to be here and to share my perspective on this, this in many ways controversial issue today. I'm here with the organization SAM, or Smart Approaches to Marijuana, which was founded by Dr. Kevin Casarett. He was an advisor for 3 administrations, Clinton, Bush, and Obama, and the only senior advisor to the Bush and Obama administration. As well, we were also founded by Congressman Patrick Kennedy. I'm going to start out here. My thoughts on marijuana just in general have developed immensely over the past few years. To be honest, I'm 25 right now, but you know, a few years ago, I did not have any conclusive view on the marijuana issue. I knew it wasn't something that I wanted to do personally as a personal choice, but on the legality of it in medical marijuana, all of these things, I had no concrete position. I began to do some research myself on the issue, and that's led me to be staunchly against legalization in general for recreational use. We're not talking about that tonight, but also against medical marijuana. I'm going to explain my reasons for why I think that we shouldn't rush into medical marijuana, as it seems that the tide today, the momentum is to let's welcome medical marijuana. And I'm going to bring up a few reasons why we might want to put on the brakes and slow down before we welcome this with open arms. I would say that every person in this room wants anyone that can be treated by a medicinal component of the marijuana plant to have access to that treatment in a safe form. I don't think there's any person here that would, stand up and say, I don't want someone that could be treated by something in marijuana to be treated by that because, marijuana is bad. I don't have any moral issues with the marijuana plant. I don't think it's like a devil's weed or anything like that. But I do look at, and I'm looking at this less from a medical perspective and more from a societal perspective. What is going to be the impact of medical marijuana on society? What's going to be the impact on youth in our society of medical marijuana? And again, it's not so much the fact, can people be treated by medicinal components in the marijuana plant? I think that we would all say yes, probably so, and we need to do more research to see what can be treated by this. Our organization, SAM, we definitely support research into this process. And I've met people, as was just shared, especially kids that are suffering from epilepsy, seeing how they're able to access cannabinoid oil and how that's able to treat the epilepsy. I think that's a great thing, that we should accelerate the research for that in order that they can have access to that and have a better quality of life. What I am very concerned about, though, is, and I think we all should be concerned about this, is the influence of corporations and businesses in our society, particularly on this marijuana issue, whether we're talking recreational or medical. Now, I'm going to bring up a reminder for all of us. It was not too long ago that there was another plant that was reputed to have many medical benefits. There were doctors' endorsements for as long of a list as you could wish, testifying to the medical benefits of this plant. And we as a society welcomed it with open arms, and now we're reaping the consequences of that. I'm referring to tobacco. There's on our site, there's videos of panels and panels of doctors and congressmen testifying to the medicinal properties of tobacco and how it should be, how it's going to be this great thing. We let tobacco have purchase a great place in our society, and we're now paying the cost at about close to 500,000 lives per year are lost to tobacco. And my concern is not necessarily that there's going to be deaths from marijuana, although that's another issue. I'm not going into that there, but the impact of an industry that profits off of addiction and that profits off of young users, unfortunately. Keith Stroup, the founder of NORML, one of the organizations that lobbies very much for marijuana and medical marijuana, at Emory University, he said, we're trying to get marijuana reclassified medically. If we do that, we'll be using, this is a quote, I'm just prefacing that, this is a quote. So he says, we're trying to get marijuana reclassified medically. If we can do that, we'll be using the issue as a red herring to give marijuana a good name. And that's what I'm afraid that we're seeing today. Again, I'm not afraid that people will be able to be treated by medicinal components in the marijuana plant, but I am afraid of the industry that's emerging, particularly the one, the recreational one, but as well the medical marijuana industry, which, as was already pointed out, in places like California, it's ridiculous. NPR wrote an article showing how in Los Angeles, for example, the number of marijuana dispensaries outnumber the Starbucks. There's about 1,000. This article was done in 2009, but at that time there were about 1,000 marijuana dispensaries in Los Angeles versus about 600 to 700 Starbucks. And this is a very profitable industry. Jermaine Shively, a Microsoft former Microsoft executive, says he wants to create the Starbucks of marijuana and mint more millionaires than Microsoft. And we have to be very careful when there are big financial interests in a medicine or any other thing, but we're talking about medicine this evening, that we're not seeing skewed search results, that we're not research results, that we're not being blinded unduly by the push of billions of dollars, which is estimated that marijuana could bring if it's legalized across the nation, that we're not being unduly influenced by that as we have been in the past. And I like to ask people a question. For example, let's look at the medicines that we do have. Would you grade how we handle medicines and opioid abuse across the nation? Would we give it an A, a B, a C, a D, and an F? A lot of people would say, we're not doing that great. There's a lot of people getting addicted to the medicines that we currently do have. And it's becoming, in certain states, opioid abuse is becoming an epidemic. And this is what I'm very concerned to see, that marijuana, we're already seeing epidemics with drugs that have gone through all of the research processes that are out there, that are FDA approved, and all of the clinical trials with the many restrictions that are required to become medicine. We're already seeing abuse with those things that are prescribed by doctors. We see abuse from that. I'm wondering, what are we going to see when we welcome an industry that has very little restrictions in terms of a medicine, as a medicine that's not FDA approved? How will people even know if they're really receiving medical marijuana? For example, the FDA recently did a study on things that were supposed to have cannabinoid oil in them, and only about 50% actually had had what they said on the label that they had in them. A lot of people would argue that this is a case for, well, let's legalize it so that we can better regulate it. But again, I would say let's first look at see how we're doing with what we are regulating and ask, are we ready to introduce a new drug that has huge financial incentive into the discussion? Now, we should do everything that we can for people that need immediate use. For example, again, kids with epilepsy. They should have access to experimental research and treatment as we're discovering this. But there's no reason to kind of give marijuana an exception that no other medicine has had. No other medicine can you self-prescribe, can you self-dose, which is often, most of the time, the case with marijuana. And we like to point out as well, you don't have to smoke, okay, I'll put it this way. The way that medical marijuana is most often used is that it's smoked when we're referring to that. And my tongue slows up. But you don't have to smoke marijuana or any other medicine to receive the medicinal properties of it. For example, we don't smoke opium to get the medicinal benefits of that. Likewise, we shouldn't have to do that with marijuana. So in conclusion, I think everyone in this room would be in agreement that we need to do everything that we can to see that the marijuana plant, like any other plant, is responsibly researched and available for people that can be treated by it. But we have to be very careful that corporations are not unduly influencing our quick acceptance of this drug that has the loosest restrictions for any medicine that we have. And again, we're already having a problem with opioid abuse across the nation. Are we going to add to that problem on a massive nationwide level? And I don't even have time to go into the potential downsides of this as well, but some of those were touched on as well. Are we ready to welcome that on a national level? Or are there more responsible ways forward than having legislators say that we are going to determine what can be treated by something that's not approved by FDA or anything else, and let people decide for themselves? So we're really encouraging us, let's put on the brakes and take a responsible route forward with this plant.
Thanks very much. That worked out much better, honestly, than I thought it might. Not sure why I thought that, but I think those dovetailed perfectly. So thank you, gentlemen, for taking the time to prepare those statements. Those of you who have questions on note cards, if you could pass them to wherever you see the beautiful and talented Jill Stahl, pass in her direction. She will collect, sort, shuffle, and then hand some to me. While we're waiting, a couple of questions we already have that have been used to stack the deck, which requires me to choose. Let me ask this question actually of everybody and give everybody a chance to weigh in briefly. So if medical marijuana becomes legal in Pennsylvania, or potentially in other states, should physicians who have a moral, ethical, medical objection be allowed to opt out and not to provide those recommendations? Maybe I'll ask each of you in whatever order you choose to weigh in on that, or you can pass if you want. Joseph, do you want to go first?
Of course physicians could opt out. The simple analogy is most gynecologists won't perform therapeutic abortions. Most internists won't prescribe cancer chemotherapy. So of course, yes, physicians can opt out.
Thanks.
Sure, I don't have any problem with it either. Just as David had alluded to in his introduction, medical schools don't teach this. Outside of California, they don't teach this. And if a physician doesn't feel comfortable and yet knowledgeable in this area, we shouldn't force them to do it.
And, yeah, I would be in agreement. If a physician does not feel this is good for his patient, there's no reason he should have to have to prescribe that for the patient.
Thanks. So another question, this is for Will, and I'll try to work these around. If other cards come in, I'll try to choose them so we don't put any one person on the hot seat more. But this is a question that we got from the audience that I was curious about, Will, for you. And that is that certainly there are, and I'm paraphrasing a little bit, but there are other substances out there, alcohol, tobacco, which you mentioned, which are also addictive, which also have health benefits. And this sounds like a leading question, but I don't think it was meant that way, and I certainly don't mean it that way. Are there ways in which marijuana is different that makes you more concerned about it than about alcohol or tobacco? Or is some of your resistance to legalizing medical marijuana and recreational marijuana essentially expressing the same concerns that you would have about alcohol and tobacco? In other words, is marijuana different, or is it all part of the same public health concern? Does that make sense?
Yeah. Love the question. One thing I think that's different about it is that I'm alive now and have the opportunity to speak up and say something about this issue, whereas in the time of alcohol or tobacco, I was not alive. I did not have the opportunity to speak up or research and, say maybe we shouldn't do this so quickly. So just in terms of timing, that's one way I like to see it, just that it is very different. What's happened with alcohol and tobacco in the past is what happened. We can't, they're embedded in our culture. There's cultural and all these other reasons why, we tried prohibition with alcohol and you cannot, it didn't work. Now, in terms of medically speaking, there is a difference with marijuana. Many studies in for example, Lancet Psychiatry Journal, and other medical journals point out that marijuana can have, and again, the debate rages back and forth, so I'm not going to say that the studies that I cite are the only studies out there, but for every study that would say there's great things to it, there's also studies that are showing, again, the Lancet recently published research showing that it can lead to an 8-point IQ loss, that it can lead to psychosis, that it can lead to schizophrenia. There are many personal stories about how marijuana has personally helped, and people will share those anecdotal stories. I can also share an anecdotal story about a close relative of mine, my age, that started using marijuana and now has mental issues. So we have to realize that there's a difference. Tobacco does not impair your driving. There's no really studies showing that it's going to impair your driving, which would cause you to endanger other people as you're doing. There's other dangers with tobacco, but there are definitely differences in marijuana versus the others, and not so much, again, that I would say it has to be treated differently. If it was in my book, I'd say let's take them all out of Main Street. Let's take all the liquor stores off the corner. Let's take out all the tobacco advertising. So I would be consistent, but my consistency wouldn't be to make it easily available to everyone.
Great, thanks. Another question, I'll do my best to sort these on the fly. We will not, just for clarity's sake, get to all of these. If you could see the podium in front of me, it looks like my professor, Judith, I explained to you a few minutes ago, had a really, really bad grading afternoon. It's just a mess up here. So we won't be able to get to all of these. But could I get you, maybe all or some of you, depending on how strongly you feel about this, to weigh in on this question, which, again, I'll paraphrase a little bit. There is a movement in many states toward legalization of medical marijuana. There is also increasing interest in recreational marijuana, certainly now legal in Colorado, Oregon, Alaska, I believe, and other states are certainly considering it. Is that a potential problem for some of the discussions we've been having about very, very careful use about marijuana as a drug? Is that a problem, and how should we, this is not on the question, but I'm asking this, how should we deal with that? I'll leave that up to you. Yeah.
This is a question that I've thought about a lot. If a state has specific criteria for medical cannabis use, and a patient does not have one of those conditions, but the state also has a recreational cannabis provision, then they can purchase cannabis on the recreational side, pay the tax, in Colorado it's 25%, and have the same product, ideally, that is quality tested, quantified, and certified to be free of pesticides, molds, and toxins? So the answer is recreational can certainly help the medical patient.
I think the two issues are frequently conflated, unfortunately. The only thing that medical marijuana and recreational adult taxed and regulated marijuana have in common is the word marijuana. My interest tonight, and hopefully the scope of this debate, is getting safe medical access to those who need it most. There are those who are strongly for and against expanding that to having adult choice, and they would cite a multitude of reasons for that. Some which, they just cite statistics of what's going on in Colorado right now. They're seeing a precipitous and dramatic decrease in violent crime and burglaries in downtown Denver. This is the epicenter of the legalized marijuana movement in the country, if not the world. And they're seeing increased tax revenues, and they're actually seeing decreased traffic fatalities. But again, I want to go back to the fact that I think we need to avoid conflating the issues. Something that Will had brought up in his concern was the impact, specifically the impact in children. I would encourage everyone to take a look at an article put out in Forbes last month, June 15th, citing a study from Columbia University. And this study, it was a 24-year study, 48 states, 1 million kids, 13 to 18. And they have shown rather conclusively that legalizing cannabis for medical purposes does not increase teen usage. Quite the contrary. Actually, they're showing that it's going up everywhere. Teen usage is going up everywhere except for the states that have legalized it for medical purposes. Perhaps, this is speculation on my part, it's how the narrative is being shown. We're showing kids that this is medicine. There's a difference between use and abuse. And when we show that this is medicine, that this is for sick vets and our sick kids and people with AIDS, cancer, HIV, et cetera, it's no longer viewed as a party drug, and kids don't use it. So there are many reasons to legalize it for beyond medical purposes, but tonight my focus, and hopefully the focus of this discussion, is for medical purposes.
If we're talking about recreational use, I could go on all night about why I think that's a terrible idea. Again, not based on I think it's some moral evil, but on the impact that that's going to have just on society based on different studies that are out and so on and so forth. But not going to go into that. It's interesting that in a lot of states that have medical, in the states that have recreational marijuana, the market for medical marijuana is sharply dropping. And one could say that, there's no need then to get the medicine kind, no need to go to the dispensary. You can get it at the closer shop or what have you. But I find it interesting, if something's truly a medicine, do we become comfortable then just buying it from a non-medical place? And I think that points to the fact that, we don't really know what we're getting in these. This is not a dosage type thing. This is not a prescription type thing. For a few people, they try very hard to do it that way. But again, it's unregulated. There's no standard on these things. And so the reality is that medical marijuana for many people is just like recreational marijuana. In terms of pure number of people that get, just the pure number of people that get medical marijuana cards across the country. Now again, there's some people that with very terminal illnesses, kids with epilepsy, that are not using it recreationally. But just in terms of pure numbers, most people that are right now saying that they have for medical purposes, it's been a guise. And studies, I'd be happy to share the articles with anyone afterwards if they want, but show that the average user of medical marijuana is a white male with self-reported back pain. I think it's very interesting. Our perspective is that medical marijuana is to create a broader social acceptance of marijuana so that we can then get to the real money-making scheme, which is recreational legal marijuana.
Okay, great, thanks. I'm going to switch gears a little bit and ask questions pointedly at one panelist or the other. So try to keep this moving a little bit more quickly and also give maybe some time to point out some different views. We'll see if that works. So to Stephen, question for you. As we've discussed, I think in all of the presentations, state laws identify qualifying conditions. Those state laws often vary. So what's a qualifying condition in Colorado may not be in California and may be in Washington or vice versa. This question relates both to that and I think broadly to whether you think it's a good idea that state legislatures should be determining what's a qualifying condition. There's actually a second part to that, which is whether as states begin going down that road, rather than having state laws determine qualifying conditions, how you think there might be benefits or risks potentially to having either a state medical board or another organization that can make more real-time decisions about what's a qualifying medical condition rather than requiring a change in law. It was kind of a convoluted translation of what was actually a fairly simple question. So apologies for that, but does that make sense?
Yes. So the two-part question, as I understand it, the first part is you take a look at different medical marijuana bills across the United States. Some of them specifically enumerate conditions. If you have one of these conditions, you can get access to cannabis, assuming you actually have this condition and you meet with a doctor who's willing to write a recommendation for it, versus other more liberal laws, perhaps, that leave it up to a doctor to decide should you get access to this or should you not get access to this. On a personal level, and I hope everyone in this room would agree with me, that I view this as a medical issue, not a political issue. And I don't know about you, but if I'm in hospice, I don't want a politician in Harrisburg making medical decisions of what I can do and put in my body. You know, I would hope that people are who are making these decisions are physicians. And if we read Dr. David's book, I'm sure we're seeing that many physicians are not trained in this yet. If physicians, people we trust our lives to make medical decisions, don't yet understand this drug, how can we expect politicians to make and understand these drugs? So one could make an argument that we should leave it up to doctors to make this issue, given that it's a medical issue, not a political issue. That having been said, I'm a realist, and I live in the real world, as we all do. And oftentimes we unfortunately have to make political concessions, unfortunately, at the rights of and on the backs of sick Pennsylvanians. I mean, if we were to take a look at the then Senate Bill 1182, there was 3 pages of qualifying conditions. Everything under the sun that has been used in other jurisdictions. And I was privy to some revisions to this, and people actually took a red line to HIV and AIDS. Meaning someone in Harrisburg decided it was a great idea. Hey, you want my vote on 1182? Take out AIDS and HIV. I mean, this is the type of political posturing that our Commonwealth, unfortunately, is right in the midst of. It's not big tobacco that's doing this. It's people with, you know, all sorts of agendas and ties to big pharmaceutical companies. The head of the House Health Department, it's no secret, Mr. Matt Baker, has accepted $22,000 plus in big campaign finance donations from the likes of Merck, AstraZeneca, big pharmaceutical companies. And he's the responsible party for not bringing it out of the House Health Committee and allowing literally people to die. So I'm hesitant to allow or to, you know, tacitly agree to allowing a list of minimally qualifying conditions, but unfortunately that's going to have to happen. But fortunately, our legislature, they recognize that they are not physicians, and this body of evidence is constantly expanding, and so we need to have an oversight board that acts with great transparency to review now medical evidence and evolving medical evidence to expand these criteria. And I'm sure Joseph can speak at better length of who would make a good fit to that. Take it.
My very simple answer is that having patients with chronic diseases on a medical board would really appeal to me for the obvious reason. They are suffering. They may have information from other people with similar disorders. And that's all that I want to say on that. Thanks.
And I would agree that it seems bizarre that politicians would be deciding who gets medicine, and especially with the wide variance across states of what qualifies as medical marijuana. We don't treat any other medicine like that, so I'm kind of scratching my head wondering why marijuana is getting this pass. Of course, my solution is that it's part of recreational, but I don't think it should be left in the hands of politicians to decide who gets access to certain medical treatment. What I do think would be much better is if we do it like any other medicine, and there are many other options for moving forward with marijuana research that we're, to be honest, not exploring, because another unfortunate reality for those that differ with the marijuana agenda, as we see it, there's a lack of funding for those that disagree with the legalization stance. But I will bring up, for example, another medicine that received an exception to move forward. This was Marinol. It had 20,000 patients. It had 3,000 doctors that participated. It used THC, so it was a Schedule I substance. And the compassionate treatment was for those, again, over 20,000 patients that were able to use this while they were studying something that was under Schedule I, and they put it in Schedule C. After there were the proper medical trials to show that it was effective, then it was removed from that special category, and people can now access that. I think that's how we should be moving forward with medical marijuana, or I prefer to say the medicinal properties of the marijuana plant. It should be done in a medical way, not in a political way at all.
Great, thanks. So we have about 10 minutes left, a little bit less. We have about 18 questions, so do the math, gentlemen. I'll direct questions at each of you, ask you for very brief responses, and then we'll try to move on, and we'll try to get through at least maybe 3 of these, if we're lucky. So, Dr. Joseph, should medical marijuana be covered by health insurance? You don't have to do just a yes or no. You could probably explain your answer a little bit.
I'm going to leave that between the individual patient and their health insurance company.
Do you think health insurance should be obligated to pay for medical marijuana in the same way they pay for statins or beta blockers? It was an easy softball for you.
I think that that's more of a political question, but I think that if the cannabis is the answer is I don't know. It's not really a medical question.
Oh, I think it is. Well, let me weigh in. This is not my question, but I loved it, so I'm going to weigh in and answer, which is, yeah, I think you could make an argument that they should for a couple of reasons. One, it has medical benefits, right? And number two, we know, or at least I think I know, there are lots of patients out there who are stopping their medications and switching to marijuana instead. As Joseph said in his presentation, people like to use medical marijuana. There's data that it gets you off of opioids, right? So if the health insurance companies pay for opioids, but they're not paying for the medical marijuana that you're buying at the corner store, then the health insurance companies are making money off of this switch to medical marijuana. I'm being a little bit devil's advocate here, if that's an adverb, but I think that argument could be made. You're still taking the fifth. Okay, fine. Mr. Jones, Will, what about diversion? We've talked around it a little bit, but how much, I know that's something we're probably all worried about to some degree, but how much diversion do we know is actually going on right now from medical to people who are using it recreationally in states in which it's not legal?
The lines are very, very blurred because It depends a lot on what the qualifying conditions are in a specific state and whether it's something that someone can pretend that they have or it's actually verifiable that they have this certain illness. But again, there's places like California, as I think you mentioned earlier, it's pretty much de facto legalization there. So there's a broad spectrum. There's also states that have very restrictive medical marijuana laws. So I would say that the abuse of medical marijuana for recreational purposes is a lot harder. So it really depends on the specific legislation in the respective states as to how much is being done. But on a pure, again, it's just on a pure numbers overall across the nation from the studies that have been done. There are some, because I know there's some that would say otherwise, but some studies that are showing that the vast majority of people that say that they use medical marijuana, it's for recreational purposes.
Thanks. Stephen, one question from the audience. We talked a little bit about the number of dispensaries recommended in the current bill in Pennsylvania maybe not be as large as it should be. What's an optimal number? It's an unfair question, obviously, but maybe the question underneath that is how do we begin to figure out what the appropriate number of dispensaries would be to provide open access? Is there a formula that doesn't involve the number of state liquor board stores near you?
There's a couple ways to approach that issue in terms of how many dispensaries there should be. We could take a look at population densities, but more specifically, let's take a look at patient counts of where these people are. Perhaps there's actually, I've been told, I haven't independently verified this, but Philadelphia has the fourth largest concentration of HIV positive people in the United States. I don't know if that's true, that's just what I've been told. So perhaps we would have more dispensaries located in this area of the state, but certainly at least one in every county. I mean, people shouldn't have to be expected to drive an hour and a half to get medication.
Okay, thanks. So I have one last question for Joseph, and then I'll ask each of you to say maybe 30 seconds to a minute tops of wrap-up statements. I'm giving you a chance to prepare. And then Joseph, you want to go last on that angle to give you a little bit of time to think. So Joseph, the question though, focused for you, is if medical marijuana becomes legal in Pennsylvania, or as it has in other states, what sorts of barriers do you see that will face in encouraging, cajoling, nudging physicians to embrace or at least consider medical marijuana as a therapy?
Thank you. That's an excellent question. Medical education is really important, and medical education comes formally through continuing medical education credits. It also comes in other ways from listening to your patients and reading some of the non-specific medical literature. So I want to very briefly address the medical education is part of the board exam for the American Academy of Cannabinoid Medicine is really excellent. As far as listening to your patients, I wrote a recommendation or a medical history for a patient out of this state, in fact, out of this country, and I watched him medicate for multiple sclerosis. He had two types of pain. One went away immediately with the first inhalation. The second changed in character. That's learning from your patient. And the third is from other sources. Will pointed out that medical cannabis is really just an excuse to get on the recreational side. I think it's the exact other way around, that many of the so-called illegal users, because we don't have it, are really self-medicating. So let's go down with the industry of the drug pushers, of the drug importers, of those who poison cannabis with pesticides just to sell it, and have clean cannabis that patients can use without fear of arrest, that are certified as to their cannabinoid content, their terpene content, and being free of pesticides.
Clapping is good, excellent clapping. So that will suffice as your closing comment, yes? Perfect. I don't think, you're not going to be able to top that. So I would just run with it. Closing comments though from Stephen first and then Will. Second to a minute.
Brief. Again, thank you everyone for coming out, giving us your attention, and again, especially taking care of our guest Will over here. I mean, we're the home of the Boo Birds. We have a jail and a court in our stadiums here, and we're taking care of our guests here. So thank you, and thanks again for having us. Just in brief summation, let's take a look at what's happening in other states and what's being done efficiently and effectively. We're not seeing zombies walk the earth here, that kids are having safe access to non-psychotropic cannabinoids. And we're seeing 24% reductions in opiate use. We're not seeing big cannabis. I mean, what's the alternative? Big cartels? I mean, let's take a look honestly at Colorado. We're seeing decreased crime, both violent and burglaries. Why is that? It's because the cartels are wholesaling, leaving Colorado, and they're going elsewhere. I would posit to everyone in this room that you can't even get Mexican ditchweed in Colorado if you wanted to. Instead, patients are getting safe access to medication that has been tested for efficacy efficiently from mold, any kind of other terpenes, and they're giving safe access to alternatives that our heretofore medical industry has been failing them. Thank you.
Truly the last brief word.
Yeah, it's been a pleasure to be here to participate in this discussion. I think that myself and everyone here wants people that can be treated by any medicinal components in the marijuana plant to be able to have access to that. And I think we all want it to be in a medical way. And I think that too often, though, the discussion on marijuana, whether it's legalization or medical marijuana, goes into false dichotomies and easy answers. I think that if we just look at, again, the wide variance in medical marijuana laws across the U.S., that it shows that this is not really medical how we're going about it. I think there's ample evidence, again, with other drugs that were very restricted, but that went forward with preliminary studies for people that really needed what they were studying, that we can follow with marijuana as well, so that, again, those that need it can have that. But the medical marijuana laws, as they stand and as we're seeing medical marijuana move forward across the country, I don't see very much that's very medical about it. I see it's basically allowing people to use marijuana if they feel it will help treat something that they have. And so I'd say let's either just go all the way, say legalize marijuana, and then we'll deal with making it medicine later. But I think calling it what we're having right now, medical marijuana, is not properly in the category. So I think it would be, again, more honest to say let's have legalized marijuana or not, versus medical marijuana as we're seeing it across the country right now.
Great, thanks. So thanks to all of you. Thanks to our panelists. George has a few last words, but I just wanted to thank you personally, myself, for being a great audience, for sticking around till the almost bitter end, for being thoughtful, for being curious, for asking great questions, most of which I regret we didn't have a chance to get to, but which I'll have a chance to ask the panelists later. But thanks in particular for taking the time to think about this. It's really easy, I've found, to have an opinion about medical marijuana. It's even easier to have a really strong opinion. It's a lot harder to think and process and listen and ask the right questions. And I really applaud you for doing that, and I applaud our panel for helping us all do that tonight. So thanks.
I can think of no better place than the College of Physicians of Philadelphia, the oldest professional society in the United States, to have had this discussion this evening. I also want to say that I hope I never need his professional services, but Dr. Casarett's manner, style, wit is just wonderful. And I'm going to put in a pre-publication order for his novel, which I suspect is going to be just amazing. I want to take chair's prerogative here. Full disclosure, amongst other things, I'm an addiction psychiatrist. Some of the worst things I've seen in emergency rooms have been people who thought they were smoking marijuana and were actually smoking lots of other really, really bad things. Secondly, one of the things that I, as a physician, am concerned about is that there are many physicians, perhaps, who are capable of treating addictions and capable of treating very severe chronic pain, but don't want to because they really don't want guys with gold badges showing up in their offices. And it's a very significant discouragement to people in the medical field. Do I think we should be regulated? Yes. Do I think self-regulation is sufficient? I won't give you my opinion, but that's a real issue. I also think it's important, and Will Jones referred to it very gracefully and didn't go there, but in a city with such significant healthcare disparities on both sides of the examining table, who are the patients and who are the treating people, the socioeconomic and ethnic differences about drug use and access to medications are very significant. This fall, we're having a program here on the pricing of pharmaceuticals, just simple molecule drugs. Next spring, we're having a program on biologicals and things that have somehow come in under the Orphan Drug Act, which are bankrupting, frankly, our systems. That's a political statement. I shouldn't make them here as the head of this place. But I would invite you to come back and listen to that. And the socioeconomic disparities of access to medicine, the use of illicit drugs, et cetera, I think is something worth considering. I think our panelists did a wonderful job. I wish more of our fellows had been here tonight. I want to thank Jill Stahl for her tremendous work in organizing this, and the Penn Wissahickon Hospice and the Good Shepherd Penn partners for sponsoring this. Look on the back of your programs. We are a medically based organization. We sometimes have fun. We're having a beer party at the end of August. No medical, if you want to talk about alcohol, sure, we can do that. There'll be 3 of us. Later, we're having, in honor of the Pope's visit, a discussion by a faculty member of Jefferson Medical College about the Shroud of Turin. People I know who've heard this talk have come out sort of thinking differently than when they walked in, as we hope you did about medical marijuana tonight. And then we'll talk about Louis Pasteur. Everything we do is at www.collegeofphysicians.org. And I wish you all well and Godspeed and thanks.
I'm the leading state sponsor of terrorism.